Welcome to AETCM. Today we'll be continuing our second session on the pediatric trauma. So in the first session, we have already covered how to proceed with the primary survey. So in this, we'll be more briefing about the secondary survey. So first and foremost, we'll be going with the chest trauma. And the mostly chest trauma is seen in the pediatric group due to the blunt mechanisms. That is mostly in your motor vehicle accidents. So that is one of the most common cause. And what all traumas will be, we should anticipate is the most common one is the pulmonary contusion. So it is most commonly seen in the pediatric group. And while we see this, what we have to keep in mind is that when we take an X-ray on a presentation to our ER, pulmonary contusion as such may not be visible in the X-ray. It is not a mandatory thing that it will be seen. So mostly it comes in the X-rays around 4 to 6 hours. So what we have to make sure is that we should be assessing the child. If we are suspicion of pulmonary contusion, we have to monitor the vitals of the child, keep on a track with the saturations, and we have to repeat the X-rays post 6 hours. And then if we are getting a pulmonary contusion, then we should make sure that first set of antibiotics are given to the child because it can cause pneumonia in the pediatric group. So this is the most common chest trauma in the pediatric group. Second one comes is the pneumothorax. And here the tension pneumothorax, chances of tension pneumothorax is high in pediatrics because there is more mobility of the mediastinum compared to the adults. So there can be possibilities of tension pneumothorax. And as soon as we know there is a tension pneumothorax, we'll go ahead with the chest decompression as usual as our adult group only. Then the other common injuries can be rib fracture, the flail chest. Rib fracture will be less common compared to that of the adult because they have more elasticity. So it will be less common, but still they can have rib fractures, flail chest, mediastinal injuries, all this can come. And coming to the investigation part, if you are suspecting an injury, the first and foremost, as usual, we will be proceeding with the chest X-ray. We will be taking an AP view. And if you are seeing a widened mediastinum, then that is a clear-cut indication to go ahead with the CT. So otherwise, primary investigation will be always our chest X-ray. And treatment is mostly we will be able to manage on the supportive therapy. If not, if there is a pneumothorax extra, we can go ahead with the tube thoracostomy, and very rarely it may lead to thoracotomy. That is very less, it is less than 0.01% only it might need. So this is with the chest trauma. Now coming to the another important one is the abdominal injuries. And in abdominal injuries, mostly it is blunt trauma. That is around 90% is blunt trauma and 10% is the penetrating trauma. And in blunt trauma, the most common one is the solid organs and hollow viscous. In solid organ, most common one is the spleen. That is, even if in adults we compare also, spleen is most common. Then comes the liver, then the kidney, and very less chance for the pancreatic injuries. And in hollow viscous injuries, it might be due to seat belt injury, it might be due to a pedestrian hitting a vehicle, and there injuries will be in the duodenum, jejunum, and the stomach. These three are the chances. Then coming to the investigations, the most important and reliable investigation is the CT. So here the advantage is that we will be able to assess the retroperitoneum also. So if there is any retroperitoneal collection also, we will be able to see in the CT, and if there is any free air also, we can identify. But in ER, first investigation of choice will be our FAST, that is focused assessment sonography of, in trauma. So FAST we will be doing, and it might not be sometimes reliable because the pediatric group may not be very compliant to our examinations. They may be twisting, turning, they may be not compliant. So in this pediatric age group, it might be difficult for proceeding with FAST, but it has an advantage that we can do repeated examinations. Like half an hour, if we see an HB fall, again we can go ahead and repeat the FAST. So repeated examinations on bedside itself we can go ahead. So FAST has that advantage. In earlier days we used to do diagnostic peritoneal lavage, but nowadays we doesn't prefer because it is non-specific, and also we will be not able to assess the retroperitoneum as in CT, and while we are doing, we may introduce air into the abdomen. So if we proceed with the CT, then we may get a false result. So nowadays we doesn't prefer peritoneal lavage. We'll go ahead with the fast in our ER, and then for most reliability, we'll go for a CT. Then coming to the indications of CT, if the child has a clear-cut history of abdominal injury, that if the child has a fall hitting her abdomen, then if there is a clear-cut history, we can proceed with the CT. Otherwise, if the child presents with tenderness, guarding, rigidity, if there is a gross hematuria, and on serial evaluation, if there is an HB drop, if the LFTs are deranged, because if there is a hepatic injury, then your LFTs will be also deranged. So in these cases, we'll directly go ahead with the CT. And if the history is not a clear-cut indication for a CT, if there is no tenderness, no guarding, if there is no vomiting, if the child's GCS is more than 13 and she can give a clear-cut history that there is no abdominal pain, there is no bruises, nothing indicative, then there is no indication for doing a CT. We just need to observe the patient and do a serial monitoring of HB so that we know there is no bleeding intraperitoneally. Then coming to the solid organ injury, mostly the solid organ injuries are managed conservatively. So when we manage them conservatively is like if the child is hemodynamically stable, we have already taken the CT and documented the extent of injury. So we have a CT facility. If the child is worsening, we can go ahead with repeated CTs, like that facility is there. If we have the facility to observe the child in PICU, and whenever the child worsens, if we have the facility to rush the child directly into OT, in these cases, we will go ahead with the conservative management. And in most of the cases, that is 90 to 95% cases, we manage conservatively. Very rarely, when there is an ongoing bleed, when there is HB drop, when there is child is going into hypotensive hypovolemic shock, then we will proceed with emergency laparotomy and angioembolization. Then in ER, when the child presents and if the abdomen is so much distended, that is in pediatric group, the difference is the child will be crying out of pain and it can cause aerophagia. So the abdomen might be very much distended. So in these people, we can put the Ryle's tube and decompress so that our examination will be correct. Once you get it decompressed, then you will proceed with the abdominal examination. So pediatric group always make sure that the abdomen is decompressed. And in these groups, there can be specific visceral injuries such as bicycle handlebar injury, elbow striking in upper quadrant of the abdomen, and lap belt injuries. These are very much common in the pediatric group. And here the difference is what is the viscera will get compressed between the anterior abdominal wall and the spine. When a bicycle hits, when there is an elbow striking the upper quadrant, your viscera gets compressed between the anterior abdominal wall and the spine. So these are a specific visceral injuries to the pediatric age group that we have to make in mind. Then coming to the head trauma. In head trauma, always we have a doubt whether we should proceed with CT or not. So in head trauma as such, like an adult, we don't have a generalized guideline when to proceed for a CT or not. But the most commonly used is this one. That is, if the GCS is 14 or other signs of altered mental status, or there is no other any palpable skull fracture, there is no need. If anything less than this, that is if the GCS is low, if there is child is already in altered state, if there is a palpable skull fracture, then your CT is recommended. So in case if these features are not there, then we will be looking for any hematomas, loss of consciousness for more than 5 seconds, or any severe mechanism of injury, or there is child is not acting normally as per the parent, then also we can proceed with the CT, but that decision has to be made by the physician. Whoever is the treating person, that person will be treating. And observation versus CT on the basis of other clinical factors such as physician experience, multiple versus isolated findings, worsening symptoms or signs after emergency department observation, if the age group is less than 3 months, and the parental preference. So these things will be kept in mind. And if all these are negative, then CT is not recommended. So this thing is what we have to remember when we should proceed for a CT in patient. So if the GCS is low and if there is an altered mental status with a palpable skull fracture, that is a clear-cut indication to go ahead with CT. Otherwise, it is based on the treating physician. Then this one you have to remember, that is a pediatric specific GCS compared to the adult GCS, we will have a difference in the verbal response. Rest everything is same only. Verbal response we have to remember. That is, one is same as only, no vocal response. 2 will be inconsolable, agitated. 3 will be inconsistently consolable and moaning. 4 will be cries but is consolable, inappropriate interactions. 5 will be smiles oriented to sounds, follow objects and interacts. So in a pediatric group, the most important thing is when we are suspecting a head trauma, we'll have to regularly monitor the GCS of child. And in that, we have to make sure that it is like GCS is monitored in this manner. This is the difference compared to the adults. So this GCS thing we have to remember. Then coming to brain injury, in pediatric group, we have to always make sure that we are avoiding secondary injuries like reduced brain perfusion, seizures, hypoxia and hypothermia. These things are very important, and as in adult only, the same drugs we will be using, that is the 3% hypotonic saline, mannitol and anti-seizure medications. Similar, management is same as that of adults, no difference. But the difference in pediatric group is, if the pediatric age group has an head trauma, the outcome will be better. That is a one difference. Treating them is very important because their outcome will be much more better. Second thing is, the chance of developing hypotension is much higher compared to the adult group, because they will be having a blood loss to the subgaleal space, intraventricular space, epidural space, because their cranial sutures will be open, their fontanelles will be open. So all these factors contribute to more of hypotension in pediatric group. And the treatment is fluids itself. You can give fluid resuscitation if you are suspecting all this. And the third thing is the important thing, that because they have more spaces, sorry, L is not there, because they have more spaces, these signs will be hidden. You won't see initially hypotension, you won't see initially the raised ICP features, ICT features won't be there. So you may not suspect, but make sure that since they have more space, these can happen in the children. So that is one important thing. And if the child is going on vomiting, there is persistent vomiting, we have to go ahead with the CT head. And in pediatric group, post-trauma seizures are very common and they might be self-limiting. We need not worry about the seizure alone. Seizures are very common in pediatric age group. So these are the difference compared to the adult and the pediatric group. Then coming to the trauma films, which all films we usually take when a child comes, that is just a briefing only. You will be taking, if you see spine, AP and lateral views, chest X-ray, you will be taking AP view. If indicated, you can go ahead with a pelvis X-ray, and CTs are all, if there is indication only, you will be taking a CT. Then coming to the C-spine injuries, it is very uncommon and it is less than 2% in children who are injured. And if it is, if we are missing a C-spine injury, it is potentially devastating. 60 to 80% of all vertebral injuries in children are cervical. So most common one is your cervical injury, and injury level will tend to vary with the age group of the pediatric. Then coming to this, this is like on the basis of age group, which all affects at which all levels. If it is between 0 to 8 years, your upper cervical spine, that is C1 to C3 will be affected. If it is between 9 to 17 years, your lower cervical spine, that is C5 to C6 will be affected. And the most common mechanism is the road traffic accident and falls. And if it is little more elder children, then most common mechanism is your sports. Then coming to the term SCIWORA. SCIWORA is spinal cord injury without radiographic abnormality. This is one thing that is different from your adult. In pediatric, transient vertebral displacement with subsequent realignment resulting in damaged spinal cord but normal appearing vertebral column on plain films. That is basically, if you take an X-ray, your film will be normal. You won't have any displacement, vertebral displacements you won't be able to visualize. But that had happened transiently and that had affected your spinal cord. So spinal cord has been injured, but when you look the X-ray, your X-ray will be normal. So those is included in SCIWORA. So if you are suspecting some injury, then you have to go with higher investigations. So here CT or MRI evidence of cord injury or ligamentous instability is compatible with the diagnosis of SCIWORA. That is, if you are suspecting, then you have to go ahead with CT or MRI. And it is reported to as 0 to 50% of pediatric spinal injuries are coming under SCIWORA. So then there is no guidelines for clearance of the cervical spine in children, and the clinical decision will be based on your history, your examination findings, and your radiographical screening. And it is better to involve a pediatric neurosurgery if you are suspecting some spine injuries. Now coming to the imagings, if you want to rule out some fractures, then CT will be better. But the problem is that some ligamentous injury, if it's there, you won't be able, it might be difficult to pick it up. So that is the thing. And also CT has a more risk for radiation. So in pediatric group, we does not prefer for going with CT. But if you are suspecting a fracture, then you can have a CT. Coming with the MRI, the benefit is there will be no radiation, and you will be also able to know if there is any ligamentous injuries. And in SCIWORA also, mostly we recommend to go ahead with the MRI. Usually for MRI, since it is a longer duration procedure, the children might need sedation. The child might not lie for the MRI. CT is very quick and fast, so sedation is not needed, and MRI is little expensive. That's all. Then coming to the clearance of high risk patient, in all children, it is better to take off the AP and lateral views of the C-spine before clearing the child who has trauma. And if you are suspecting, as we have already told, if you are suspecting some fractures, then you can go ahead with CT. If you are suspecting some ligamental injuries, then you can go ahead with your MRI. So that is about the secondary survey. This is how we monitor in a resuscitation. That is, once you have made you have done the primary survey and secondary survey also, continuous re-evaluation of the child should be done. You should be monitoring the vital signs, the mental status of the child, the perfusion, the filling pressures, the urine output, and you can also look for the lactate and base deficit in the blood gas analysis. So these things has to be monitored in the pediatric group. Then coming to the disposition of the child, if child needs observation, you should admit and observe the patient. Whoever has a refractory hypertension, intracranial injury, intrathoracic injury, intra-abdominal injury, and pelvic and long bone fractures might require surgical intervention. So we will be proceeding with the surgery. So this is with the pediatric trauma. So with this, we'll come to an end.